series of smartphone apps that we've selected. We've selected some that are specifically women's health, some that are more internal medicine. Towards the end, we're actually going to ask that you share your favorite apps with us, and we can kind of go through what's good and bad about the ones that are available, how they help clinical decision making, and sometimes actually how they hinder it. This is not.
I get you.
So just so that we're all kind of on the same baseline here, there's actually two types of phones, so two different app formats, Apple versus Android. There used to be many more for Apple than for Android platforms. I don't think that's quite as true anymore. The ones that we have selected to review today are actually available for either, so we didn't want to exclude either group. The next thing is that some apps are single topic, some are multiple. So some of them have calculators that you can use for multiple subjects. Others are just for one particular topic. And then next is free versus fee. The majority of them are free. Some of them, that means they come with some ads. I'm going to show you at least one of those. And with that one, every time you pull something up, the ad pops up and you've got to close it. I particularly find that a little annoying, but the other option is that some of them do charge, and I think the most expensive one is $9.99, so they're not really expensive, but some of them do indeed charge. Some of them are simple screening algorithms where all you do is plug in numbers and it gives you a score. Others are actually much more, give you much more information. Some of them will give you management recommendations. Some of them will give you references. Some of them will allow you to actually print a report or email a report to a patient or to a chart. And those are actually a little bit more useful. Keep dropping the phone. So the first one we're going to look at is actually the American Society of Colposcopy and Cervical Pathology, which actually we did look at briefly when I gave my talk on PET screening. That is one of the ones that is a fee, so $9.99 download for either Apple or Android. And this is one where you can enter patient-specific information, or you can follow just an algorithm in general. So.
All right, so let me slide that over, and go ahead and plug up.
While we're waiting, look at your breakfast. What is your microbiome think of it?
Dr. Pizek, my microbiome isn't even awake.
Oh, your microbiome is always awake.
I'm trying to wake them up.
In terms of any app, there's pros and cons. And so one of the pros is this is fairly user-friendly despite how complicated pap smear algorithms currently are. And you can choose to enter individual patient information, or you can just follow an algorithm. But one of the cons is just this, which is that unless your phone is fairly large, the print can be fairly hard to read, and you kind of wind up sort of turning it sideways to try and get it big enough to be able to see, and then you kind of have to move it across your screen as you're trying to figure out what the answer is. So that, for people with the larger phones, that's not quite as much of an issue, and perhaps for people that don't need readers, it's not as much of an issue. But I particularly found myself sort of doing one of these numbers with this app. So can you go back again?
Yeah, I see the slide.
Okay. Yeah. So again, for our patient, we had negative cytology but a positive HPV, which is something that seems to come up relatively frequently right now. And so your options are going to be to repeat testing in a year is acceptable, and so that's most likely what we would do. All right, so our next Next patient is a 40-year-old who has a low-grade SIL cytology and negative HPV. So she had a repeat PAP 12 months later, which was negative. And so the question is, now what? So we've got a 40-year-old who has again, a little on the hard to read side. But
You want to flip it?
okay, so okay, so she had LSIL with a negative HPV. We repeated in a year. It was negative, and so now the next step is to repeat co-testing at 3 years. Thanks. I would say this is another one of the things about this app that I don't particularly like, is that often when you get to the end of the algorithm, it just says to manage per ASCCP guidelines. And so then you're left going back trying to find the guidelines as opposed to just being able to continue going down the algorithm. Okay, so all of them have pluses and minuses.
Imagine those will be things that they will add over time
Maybe a hyperlink.
or update over time. Yeah.
All right, and we've got one more of these. I think we're going to need a second. Okay. So our last one is going to be a 37-year-old G2P2 whose cytology was negative, but her HPV was positive. And so one of the options is actually to order HPV typing so that you know, are you dealing with a high-risk HPV or not. Again, some of that may be dependent on insurance coverage, lab availability, that sort of thing. But in the event that we were able to do that, and we did. So for this patient, we've got a 37-year-old who is HPV positive. So in this case, we went ahead and did order typing, and it came back positive for high-risk HPV. So she would then go to colposcopy, and further management would be depending on what her pathology returned. Any questions about this particular app? Any comments about you've used it, you've not used it?
Anybody used it? Oh, somebody's used it back there. We have some people. You like it? Yes. It works.
Yeah, I find myself just double checking even when I'm pretty sure I know, just kind of quickly running through it again, because things have gotten so complicated. Is it 3 years, is it 5 years, that kind of thing.
And any other cases that they might want to plug in?
Any other cases that you particularly would like us to run through the app? Any particularly difficult ones or ones where you got an unusual answer that you didn't expect?
I don't have a particular case, and there's probably an answer to this I don't know. When you keep getting, when you keep getting HPV positive, negative cytology, and then you repeat it in a year, HPV positive, negative cytology, I guess the best thing to do is to do a 16-18.
Right.
But then if it's 16-18 positive, you're doing a PAP and a colposcopy almost every year. That's what I feel like the trap we're falling into, is that every year somebody comes for a PAP, they get HPV positive, they get a colposcopy. And my question is, does anybody, I don't think the guidelines are clear on this. If you do a PAP HPV positive, then a col, the next year when they come back with a PAP HPV positive, do you reset it and just repeat a PAP in a year, or do you now cult them every year? Because even if it's not 16-18, it's still a high risk.
Right.
Is there an answer to that?
I think you're right. I think that's a gray zone. And I think a lot of people would say err on the side of being conservative. The other thing you could always consider doing is getting oncology involved. And I suspect some point they would probably need to.
They would what?
I suspect at some point somebody's gonna suggest a leaper account thinking that you're missing something.
But they've got normal cytology.
Yeah, yeah.
Wow.
That's a question.
Comments on that, what people do?
Yeah, just a comment. I would, depending on the age of the patient,
Right.
I would definitely err on doing a leap, and I'm conservative with my leaps, so that basically I'm getting a bigger sample, bigger biopsy. And I can't tell you, I had a couple of patients that went to hysterectomy, had normal cytology, didn't have any abnormal paths, and the hysterectomy pathology came back as CIN3. So I've had that. You know, I live in Fayetteville, it's a military town, and I see a huge number of abnormal pap smears. So honestly, I'm more conservative than the guidelines are because I see so much high-grade dysplasia. So that's what I do. I figure it doesn't hurt to do that. But I've also seen people coming to me from WOMAC who were told, oh, you don't need a pap smear for 3 years. And the first pap smear I did was carcinoma in situ. That was 3 years later. So I've seen different scenarios. So I'd rather be safe than miss that one person that will get cancer. So that's my experience.
And I was actually at the ACOG national meeting right after these guidelines were released, and there was a very robust discussion about them that involved several oncologists. And the emphasis they had was that these are guidelines, they aren't restrictions. And so clinical judgment, always is the number one. And, I don't think anybody faults someone for saying that my clinical concern is that I need to be more aggressive in general. But the point was that these are guidelines not supposed to keep you from being able to use your clinical judgment.
And also looking at other risk factors, like sure, smoker. I'm in GYN oncology as a nurse practitioner. And what are yes, there's guidelines, but it seems like we do it sort of on a case-by-case basis. And and 2 different doctors in our practice both practice different ways. So, like you're saying, it's more just a guideline and looking at the actual patient rather than just an app, even though it would be easier just to be able to kind of go through it like a cookbook. It rarely is in our setting as well. So, I think this one was good.
Right, and at that same meeting, we had an oncologist rolling his eyes, who could name a number of people that first pap on a 19-year-old was carcinoma.
It happens.
Are you aware of any studies that there is increased risk of or increased prevalence of cancer amongst younger populations since we have gone to these new guidelines?
No. And again, part of the reason for the guidelines is that the incidence of cancer in the very younger population is so very low.
We have a comment right down here.
It is a comment.
This is for the webcast people, by the way.
That's why we do this. I think that we touched upon this a couple of days ago about guidelines in general. Remember, guidelines haven't been involved in many of these committees. It's difficult, first of all, to develop a guideline for every single patient that we're going to see in our practice. So in general, remember, guidelines are for the general population. They're not for the exception. They're not meant to cover 100%, or we'd like to, ideally, but rarely can that be done. So guidelines are for the general population, and the exception is meant for that one interaction in the exam room between you and that patient's family, and then that now becomes the art of medicine. So just keep that in mind when you think about guidelines, just in general. It doesn't matter what the guideline is.
Yeah. These are just tools.
Any other comments?
There's one.
Yes, back to you.
I have a question just for the audience. I don't know how many of you are gynecologists, but just in general, that scenario with the 19-year-old with the pap smear. I have patients that come to my office, they were sexually active, been sexually active since the age of 14. I recently had someone coming in to remove an IUD because she wasn't happy with it. The health department had put an IUD when she was 13. So she'd been sexually active at 13. So at 18 or 19, if someone comes in, yeah, I'm going to do a pap smear. I don't care what anybody says. Even I understand that, that at younger age, if it's abnormal, can clear and so on. But I don't want to miss that carcinoma in situ. So what I was wondering what other might be on that. I'm doing pap smears on women younger than 21 years of age because I definitely do.
Okay, she's asked a question. So, how many of you do pap smears on young women? I have a lady who was 12 and was pregnant in my practice. So, again, how many are going to do that pap smear early if she's sexually active? See, there you go. Virtually everybody. Well, many of us don't do pap smear. Okay, any other comments about that app? Very good. Okay. Right.
Okay, so next we're going to do the Cvd Risk Assessment. This is also a free download for Apple or Android devices. This was jointly published by the American College of Cardiology and the American Heart Association. It does estimate both the 10-year and lifetime risk of atherosclerotic cardiovascular disease. Its main utility, though, is as a tool to decide about initiating statin therapy.
It also helps your patient. You know, you're looking at the screen. I do this with the patient, so does Dr. DePetty, and I'm sure a lot of you do this with the patient. And you look in there and you say, okay, Mrs. Medlap, you know, you're a smoker and your hypertension's out of control and yada, yada. And we calculate your risk. And then the patient looks at that and says, oh, that doesn't look good. And so you say, well, let's see what we can do if you stop smoking, right? And then, you know, you can go through again. And it's a really quick calculation that says, oh, look, my risk is what happens much. So again, it's a nice app to educate patients because it shows them the numbers and you can tell them what they can do. And if they change your risk factor, you can go through again and just quickly calculate for them. So it's a nice education tool. Okay.
So again, just briefly looking at the pros and cons. It is easy to use. You can quickly assess the individual patient's risk and review statin recommendations. It does factor in their age, their race, and the presence of hypertension, diabetes, and smoking. It does include a section on lifestyle recommendation for patients. One of the cons that I frequently run into is that the lifetime risk is actually only calculated for up to age 59. And it only utilizes total cholesterol and HDL. It actually doesn't consider LDL, and I'm going to show you one later that does. That's always seemed really odd to me, and maybe we can get Dr. Petty to comment
It's
about it.
because many times you don't have the LDL. You have the total cholesterol.
Yeah, the LDL can't be calculated if your triglycerides
Right.
are high. So you can't, you know,
It's a
you can't let that
calculation,
be
it's
your,
not a measurement.
right. You can't let that be your stopping point because that's going to exclude all of your patients with diabetes. Just kidding.
And the other thing is that it does not factor in family history at all. So,
That's
okay.
interesting. It's interesting about this app that what they did. The app is really not all the data. And so I tell people if they take care of folks who are over the age of 70, for example, you're going to have to use the database that's online at American Heart. And there's a website you just go to. It also, so it goes up much higher than 59, the total database. And Don, help me out here. The 45, you can get down. Can you get down to 45 with the one on the website? This one.
I think you can.
So the one on the website has a much larger database. So if you're taking care of people at both ends of the spectrum here, you may want to use the one on the website, or the American Heart Association website, rather than the one on your phone. The other thing is that this database, remember that the database is new, and they looked at these risk factors because they were related to preventable deaths. We were missing, remember Dr. Petty's slide yesterday showing us the heart attack rate the heart attack rate in people who are Black Americans. Very high. Black American males, Black American females are about the same as Caucasian males. So again, this database said we're going to fix that. And in doing that, it slanted against some people that I'm very fond of, older women. Okay, so sorry, good. So next.
This is your case.
Oh, this is my case. This is a 30-year-old female with type 2 diabetes for 10 years. Okay, so statistically, since her A1C is 7.2, so she may not have coronary artery disease. I've had a patient who's 18 with a myocardial infarction who had type 2 diabetes since she was 7 years old. So remember, that causes you to have coronary artery disease early. She follows an excellent food plan. She exercises 30 minutes 5 times a week. She does small bouts of brisk exercise. Okay, her lipid panel, total cholesterol 186, triglycerides 106, HDL 68. Oh, isn't that good? And her LDL is 97, less than 100. The ADA breakpoint is 100. LDL of 100, you're at risk. And so, yes, she has a family history of early cardiovascular disease, doesn't smoke, and has no albuminuria. Now, my question to you, before we use this app, my question to you is, if she came into your office, should she be on a statin? So think about that. Just quickly in your mind, look at this woman in your office.
Yes.
Yeah, look at all the yeses. Yes, right. Okay, so what does the ADA say? It says if you're over 40, you ought to be on a statin. Over 40, on a statin. And that's the British Health Prevention Study. You really should. Those people had a 50% decrease in myocardial infarction, no matter what their LDL was, if they're on a statin. So, what are the risk factors? ADA says any risk factor, moderate dose statin, it doesn't matter. He told me that's right. Thanks, John. I like it. That's right. He agrees with me. That's so.
No, we rarely agree with the
Rarely
ADA.
agree with each other. And so, yes.
Not you, Ronnie.
She has a family history of early cardiovascular disease. So, yes, she should be on a statin. So, very good. They did this without the algorithm. So, the ADA says yes. You say yes. What does the app say?
Well, the app is not for the yes. The app is for moderate or high intensity.
Right. Okay. All right.
You already got to yes.
We already got the yes. Okay. So
the
yes.
first thing the app says is that her 10-year risk is only calculated for age 40 to 79.
Oh, I know. So again, and even the database is going to help you out here, but your common sense is going to help you out. This is a lady with a huge risk factor for cardiovascular disease. And when you meet her, you're going to put her on a statin. So what are you going to tell her about becoming pregnant? All of you GYN folks out there, some people become pregnant without telling us, Don.
I know.
What are you going to tell her? What about pregnancy? You can't be pregnant on a statin. Well, I don't want you pregnant on a statin. So what are we going to do for that lady?
Well, I think you would probably, if you're planning the pregnancy, then you could take the statin off and you could treat it with something else.
Right.
Yeah, like a bile acid sequestration.
Absolutely. So
Yeah, it's still not that bad.
Did everybody hear that? She can be on the statin, that's for sure, but you've got to have her very carefully monitored for pregnancy. And if people tell me, oh heck, I just want to do it and I don't want to care whether I'm pregnant or not, then I tell them, you are on a bile acid binding resin because your risk of cardiovascular disease is really high. And the endocrinologist across the aisle there, you want to jump in and tell us maybe what you do? Did I lose my endocrinologist?
He's right there.
Right here. I might do some non-invasive testing on this patient, like CIMT or something like that if she's planning on getting pregnant, and just see what her actual vascular age might be.
Is this the only case I have on this one?
No.
Okay, good. Okay.
And just so everybody's on the same page, CIMT is
Carotid intermediate thickness testing
So,
or coronary calcium scoring, something like that.
okay, so, go back. Okay, so
Do
we.
you think that's reasonable?
I probably wouldn't, only because I don't know the accuracy. Everything is local, but no one would fault that approach. Looking for other surrogate markers, CRP, high sensitivity CRP, for instance.
I think I'd probably agree to do a little more. I'd probably look for an HSCRP on this lady and see how we're doing. The other thing
Clearly,
is
that's appropriate.
coronary artery scores. Just that I don't know that I do it on somebody. Well,
30
yeah,
is young.
young. But on the other hand, you know, if you're, how do you have trouble getting a coronary artery calcification scores done on your patients? They're kind of expensive. But you know, if the key here is, if you have a heart hospital that is just a, well, I would say a coronary artery bypass mill, like we have down the road, they will do your patient's coronary artery score for $49. Walk in, say, here's my $50, I'd like to know my coronary arteries. They'll do it because, and I called because I had a patient that didn't have $50, she was very poor. And she had 75 years old, she had diabetes for 30 years. I said, this lady is just, you know, and she was having some vague symptoms. So I sent her down there. She had shoulder pain, actually. Remember, Dr. Cvd discussed that yesterday. And so I sent her down there, and I said, she can't pay it all. And they said, oh, no problem, because they knew that she was going to need a coronary artery bypass, for which her insurance company would pay, and that's how they make a buck. So if you want coronary artery scores and you can't get them, look around for one of these places. They really do do them for practically nothing or nothing because you can't afford it.
Does well call have outcomes data? Or are we just doing this because she's pregnant?
Please, microphone. People at home.
Say that again, I'll repeat the question.
Does well call have outcomes data?
Is there outcomes data? The answer is no, there's not large series of outcomes data.
If you would repeat, the people at home can't hear this.
Oh, I thought I did, but I didn't. I didn't.
No, my question was, are we doing the well call only because she's pregnant, or is there outcomes data? Yeah. And I was Googling it real quick too, and there is no outcomes data that prevents that.
There are small there are small population studies, but there's not large population outcomes.
So this lady would be on a less than ideal agent.
Cholestyramine has data. Cholestyramine has excellent data that it decreases heart attack. And pregnant women, particularly if they have, oh, help me out here, if they have the jaundice, cholestasis, right? You can use that really quite nicely and just tell them they have to eat a lot of fiber because otherwise they'll get really constipated.
The difference though with the data, what Dr. Bizak is referring to, actually the original study was with cholestyramine, the limited research clinics, primary coronary prevention trial, but those were people with very high LDLs. That's the difference.
Right.
Again, remember, I like what I just said because it's almost like I'm a prophet. This is the exception, and the guidelines are really for the rule. And that's why we, these need to be discussed, and there's many different ways to approach this patient.
Right, see, that's the thing about these interactive things is you can go online and find the answer.
I've got one more comment.
Yeah.
I have patients like this that are similar, that may have more risks than she does, but at age 30, the question they ask me is, if I make it to 80, does that mean I need to be on the statin for 50 years?
Yeah.
And I just think that that's hard to convince somebody to do that.
Mm-hmm. It is, no doubt.
So, if you get a test that shows their vascular age is 30, they don't have established disease, then I think you could monitor that. And I live in Charlotte. We have very good cardiologists, I think, that do these tests well. So we could monitor her periodically every 2 to 3 years, and if she begins to develop some evidence of disease, then we can initiate therapy at that point in time. I think for my population, it's a hard sell to say that's 50 years of statin therapy. We don't really know, I think, what that does to patients long term. She may get pregnant, she may not get pregnant. I think that's kind of a hard sell in my mind.
Anybody else have a comment about this one? Okay. Well, I think that you bring up a very good point that Dr. Cvd brings up every year, and the bottom line here is, again, this is a patient sitting in your office. No matter what the guidelines say, you and the patient are going to decide what to do with your statin, and statins have side effects. So, okay, I think we're probably ready to move on. My cases are sort of repetitive. This is a 40-year-old female with type 2 diabetes for 10 years. The same person, except she's 10 years down the road. So we didn't trigger. We decided to be conservative. We say, okay, but this lady has no family history of early CVD, no tobacco, but she has albuminuria. And albuminuria has an 80% correlation in people with diabetes with coronary artery disease. Not that it has anything to do with causing it, but when your kidneys are having problems with glycosylation of basement membranes, your heart is having problems with glycosylation of basement membranes. And you're beginning to get probably calcifications, you're probably beginning to get fatty streaks and plaques. So, again, should this lady be on a statin? We can use our calculator. There we go, moderate intensity statin. So virtually everybody with type 2 diabetes that you meet should be on a moderate intensity statin unless you and they decide that that is not for them. Okay, ready?
Joan, what was the risk? What was the 10-year risk? I missed. It was there, but
It was there, right?
Okay.
yeah, because that'd be interesting because this gets into discussion between moderate and high
High
intensity.
intensity, right.
What did it calculate?
She
the
has
risk
no
at?
risk factors here. She's got diabetes.
Well, it's got to be greater than 7.5. Oops.
Hang on, I can wait.
Oh,
That's
yes, yes, she does. But tell them why.
Because it recommended a moderate statin.
No, oh, no, that's backwards.
I went backwards.
Tell them why she's going to be 7.5. She has diabetes.
It's age and diabetes.
Age of diabetes. She's 40.
Yeah.
So again,
She's 40 now.
ABA says anybody over 40.
Let's see.
Actually, cholesterol is 140.
No. Yes, 7.
So lifetime risk was calculated at 39%, and 10-year at 0.3.
And that 10-year risk is something you can use when you're, to his point, that you can see the 10-year risk of this lady is very, very low. The 10-year risk of a 30-year-old is going to be extremely low. So if you wanted to wait and monitor, but you got to be sure that you're watching them carefully.
But I think this is actually probably something we want to focus on too, right?
The lifetime.
Right, this is a
Well,
lifetime.
because this is where she's calculated to be right now. This 8% is her risk with optimal risk factors. So this is, and on the next, this is where the lifestyle, so underneath where it tells you, it recommends the statin, it actually goes on and does give lifestyle recommendations, which again are nothing that we don't all know, but I think that we all do know that somehow showing it to a patient in writing on an app, not just coming from the doctor, sometimes seems to make more of an impression. So I actually often scroll down and say, all those things I keep telling you every visit, this is, and because it will modify risk factors, or modify your overall. Okay. We done with that?
I think we're done with that.
Okay.
Oh my goodness, we
You
got
got
one
one
more.
more?
Yeah. Okay, one more. Okay, so this is a 30-year-old African-American lady with a 2-year history of hypertension. Now this is Dr. DePatty.
Now what do I do?
Well, now what do? Talk the way you always do, Don.
Well, she's controlled.
She's well controlled, lysinopro. You got a microphone there. She's well controlled, lysinopro. Blood pressure is 110/80. Oh, come off it. BMI is
This is your case.
BMI is 45. She's a non-smoker, non-drinker, lipid panel. Total cholesterol 250. LDL 160. Should she be on a statin? There we go. And you're calculating her here.
So
I would
this is
say
going to
no.
be another one where it's not going to, it gives us a 10-year
No.
because she's under 40.
She's under 40.
But we've got a 50% lifetime risk, which can theoretically be optimized down to 8.
She's a non-smoker.
Smoker.
Did I get that right?
But no, that'll go down.
There we go.
It should. You have to refresh it, Joan. While you're doing that, I would say no.
Good to know.
Well, I didn't put her on a statin, but again, she's one of these people you're going to look at very carefully. If people have a very high cholesterol and they have a very high LDL in the 190 range, you got to be very careful with those people because they may have familial hypercholesterolemia. You want to chat about that while she's doing? Oh,
Usually the LDL is greater than 190. So
practice. And,
For the
and
heterozygous.
how soon do you start putting those people on a statin?
With
Familial
Right away.
hypercholesterol? Familial hypercholesterol.
right away.
You all know what that is. Why don't you
Right
check?
away. Yeah. Children.
Yeah, so why don't you check about that?
Well, if they are familial, if they're heterozygotes, the
Because if you
homozygotes
see
are going to be in
teenagers,
pediatrics.
that's important.
But we're talking about the heterozygote FH disease. The LDL will almost certainly be greater than 190. That's in the guidelines because even in the guidelines, if your LDL is greater than 190, you start a statin. In the AHA, ACC guidelines at least. Those individuals have tremendous high risk for, they already have accelerated atherosclerosis, as was already mentioned, and so they would immediately be placed on the statin.
So that's when you see
And that would
someone-
be lifetime, unless there's newer drugs that come along.
So,
LDL.
Don, why don't you talk a little bit about statin choice? So let's say it is this exact same patient and her LDL is 190. What would you choose and why?
We would first start first of all, you would first start a moderate intensity statin, but I would, in those individuals, I would go right to a high intensity statin after they've tolerated the moderate dose, and I would get them on a high intensity statin.
And of those, do you have a particular favorite or? Are you
No, well, the two high intensity statins that are recommended are atorvastatin and rosuvastatin.
And based on insurance coverage costs, is that
No,
make the decision?
that would have to be considered as an individual basis, but the
Right.
guidelines specifically state those are your two high intensity statins.
But
so
atorvastatin is
this is
generic.
Yes, atorvastatin's generic.
Generic.
atorvastatin, okay.
Yep.
Both are available generically now.
Up, Con's back.
Good.
People at home? Somebody in the back want to say something?
She said both are available generically.
Oh, okay. Okay, so but that's important to remember. Somebody with a really high LDL, no matter where you find them, no matter when you meet them, you got to get those people on a statin because if you don't, they're dead.
And by the way, Ronnie, including females,
Oh, yes. I mean, you know.
because they are often poo-pooed. I've seen it in referrals. I don't know why, but that's my experience.
Okay.
All right, so
Leaving that one.
Premenopausal.
next we're going to look at the Breast Cancer Risk Assessment, BCRA app. This one is also a free download for either app or Android. This is based on the Gale model, and Dr. Mitchell Gale is an NIH senior investigator who was involved in the development of this. The app was developed by scientists at the National Cancer Institute and the National Surgical Adjuvant Breast and Bowel Project. It's used to assess the risk of developing an invasive breast cancer in women without a previous history, a previous diagnosis of breast cancer. And that includes carcinoma in situ. So in clinical practice, it's easy to use. It does look at age, race, the age of first menstrual period, and first live birth. It does look at first-degree relatives with breast cancer and the patient's individual previous biopsy history. This is one of those where an ad pops up after each assessment. And at least on the Android version, we'll see that it actually cuts off the last few lines about lifetime risk, and that may be a phone size issue. It does not take into account lifestyle factors like alcohol intake. It doesn't make any recommendations regarding management, and this is not one that you can save or you email the results to a chart. It's kind of a one-time thing. So. That's what it looks like. So our first case is going to be a 4-year-old Caucasian female whose first period was at age 12, first childbirth was at age 35. She's adopted, so we don't have the benefit of family history. She hasn't had any previous breast biopsies, and so the question is, what is her risk of invasive breast cancer? This one, it actually fills the answers and you have to change them if they're not correct. So no, she does not have a history of breast cancer. Her age is 40, so we have to. Her age at the first menstrual period was 12. And then this one's a range. Her first childbirth was age 35. We don't have any family history, so that's unknown. She's never had a biopsy. And she is Caucasian. And
There's your
here's
ad.
the ad that's gonna pop up every time you try to get your answer.
That's what I'm saying. So what do you think? She's high risk, low risk? Oh, waiting for the calculator.
Okay, so her 5-year risk is estimated to be 0.8, whereas the average woman her age is 0.6. Her lifetime risk is estimated to age 90 to be 13.6 versus the average woman who's 12.4. And again, as you can see, my comment about it cuts off the remainder of the lifetime risk, and again, it may be a phone size issue, but that's where my criticisms of this particular one. Okay, our next case is a 50-year-old African-American Nulla whose first period was at age 10. Her mother had a mastectomy for breast cancer at age 60. She had a breast biopsy last year, which she tells you was atypical. And what is her risk? So she does not have that. She is 50.
I see a problem with this app. I lose patience with it, trying to figure out how old she was and put it in.
First birth. She had
Relatives.
Mother.
So in this patient, her risk is calculated at 3.6% 5-year risk versus the average woman of her age at 1.2. Her lifetime risk is actually calculated at 24 versus the average woman of 8.9. So obviously this is someone who's at higher risk. And again, this particular app isn't going to tell you next steps. What do I do with this information? Which there are some that do, but this particular one does not.
What do you tell about alcohol? Anybody in the audience know that? What about alcohol and breast cancer? It's kind of controversial. What are you doing? What are you telling your patients? Folks in the GYN folks, right over there. Good, thank you. What are you telling them about alcohol? What are you telling them about fat? Eating fat.
Well, I'm always telling them that eating fat and drinking alcohol is bad, but in terms of breast cancer, I thought the data was that the only dietary influence on breast cancer was alcohol, and that it wasn't the fat.
Right.
So if that's why you're discussing fat and alcohol in terms of breast cancer, obviously you're discussing it for other reasons as well.
Okay, any other comments about this? Oh, right over there. Oh, this is no, I knocked everybody's orange juice over, but just.
Do you know if there are apps that have that next step? I mean, do you use any of those? Because that's fairly new to me, where I'm getting patients coming back actually from radiology with mammograms, and they've got this calculated by somebody at the radiology clinic, and it comes back to me. And of course, then it says, now maybe you should think about an MRI, which I can't get paid for. So I didn't know if you had any that give you a next step.
I don't particularly, but I wouldn't surprise me that there's one either being developed or already developed, but I'm not aware of it. There's one back then.
If the calculated risk is more than 20%, the the insurance would pay for an MRI, and I have some patients that I have pre-authorized based on game model with the risk more than 20%.
Oh, did everybody hear that? People are falling here.
Okay. If the calculated risk based on game model is more than 20%, you can get pre-authorization for MRI by most insurances, and I have several patients that I'm doing that for.
How about,
Is that a good piece of info? Thanks.
was that private insurance or Medicare, do you remember?
Private.
Private insurance.
Blue Cross Blue Shield
Yeah.
has been covering it, yeah.
In our area, Blue Cross Blue Shield will do that too. If you're high risk, they will okay ultrasounds and MRIs and so.
They also recommend that we do MRI annually and also do mammogram annually. So kind of set them apart every 6 months, one or the other. That's what the recommendation is, and they are covering it.
And they're covering it.
Yes.
Okay, they suggest you do that for the folks at home. They suggest you do your MRI annually.
Yes.
And ultrasound, she was saying, she was alternating every 6
And
months. So
alternating
ultrasound, 6 months, and then
Ultrasound, but mammogram.
Mammogram. Okay, so MRI or mammogram alternating annually or every 6 months.
Yes.
Okay.
Because they say MRI does not replace mammogram. You still need to do mammogram.
then of course, is that a standard mammogram?
Standard.
Standard mammogram, okay.
Yes.
All right, so this is our last breast cancer case. So this is a 45-year-old Hispanic who reports her first period at age 12, first childbirth at age 18, and last one at 39. She believes that both her mother and grandmother had breast cancer, but she isn't sure because her family doesn't discuss those kinds of things. And I'm sure we've all had patients come in and say, well, I can't ask my mother, I can't talk about those kind of things. She has had 2 normal mammograms to date and has never had breast biopsy. So obviously, in order to use the calculator in this, you have to kind of make a judgment call as to whether the possible family history of breast cancer is true or not. I would probably err on the side of you calculating that it probably is true, although again, we don't have good history there. So she does not personally have a history. She is 45. Her first menstrual period was at age.
By the way, that calorie counter just came up in the ad, MyFitnessPal, really good. And your patients can use that, it tracks. It used to be free. Now that it's advertising, it may be a little costly, but it's a really nice calculator. MyFitnessPal.
A lot of those come on the devices now.
And some of them, you can buy your device with a package,
Oh, right, like the Fitbit stuff like that.
like Fitbit, your Fitbit.
Okay, so for this patient, she calculates to a 5-year risk of 1.7 versus a general population of 0.6. Her lifetime risk is calculated out to age 90 at 18.9 versus the general population of 7.7. And again, that would obviously be very different if it turned out that this uncertain family history was not correct. Any questions, comments? All right, so next we're going to move on to Dr. Piziak's favorite fracs, the Fracture Risk Assessment Tool. This was developed by the World Health Organization and International Osteoporosis Foundation, also a free download for either format. And this is going to assess the 10-year probability of both a major osteoporotic fracture or hip fracture. The pros, this actually assesses multiple variables, including country of origin and ethnicity, age, sex, height, weight, personal and family history of a previous fracture, smoking and alcohol use. It allows height and weight to be calculated either metric or imperial values, so you're not trying to flip back and forth. You can actually save this information. You can't print it or email it. cons, you actually have to input the answers to like 14 different questions in order to move forward, which it takes some time. I'm not necessarily sure. Do you use this in the office with the
I use
patients?
this in the office at click and point. I mean, it's really pointless. It was really, really quick. I'm sorry there are 14 different risk factors and variables, but they're there, and they're all the risk factors we know and love, and you just point and click. It takes me about I'm really slow. It takes me about 30 seconds to get these answers in.
And it does not make treatment recommendations.
No, luckily it does not make treatment recommendations because the treatment is really very variable and depends upon the patient. Okay, this 44-year-old lady fell from a standing height in her kitchen and fractured her left femoral neck. She was my patient in the lecture. She had surgical menopause at age 36. Early menopause. No hormone therapy. 25-hydroxy-D level is 36. So she's okay there, right? She's in the ideal range. Height was 64 inches and her weight's 156 pounds. And one thing I love is that you can just put this in the side and it calculates it and puts it back into the regular algorithms. You don't have to calculate it and type it back in. And let's see, calcium and creatinine are normal. And we're going to look at the calcium, the vitamin D, and the creatinine before we treat anybody for bone disease. And the question is, would you treat her with a bone active agent?
So first we have to pick her country of origin.
And you can set this in your office. You know, you can have it already set for U.S. So,
Do you remember her ethnicity by chance?
Her ethnicity, she's Caucasian.
And she is 44.
This also works for men, as you can see. And again, all you do is just type this into the corner and it flips it right over into the calculation. You're doing this on your phone, though. It's really laborious, isn't it? I would suggest you go to the website. It's really much easier.
Much easier on the website.
She fractured.
Well, this is very important.
About adding all that.
Age and fracture history are incredibly important. If you have a fracture, it defaults to age and weight. Because remember, obesity used to be thought to be a protection against osteoporosis. It is unless you have diabetes or sleep apnea, and then it's no longer protected and the osteoporosis risk goes up. Okay, currently smokes, no. Glucocorticoids, no. Steroids, that's within the last 3 months, or chronic small doses intermittently. If you have epidural steroids 3 times a year, your bones are at risk.
Alcohol.
Alcohol.
Does she consume 3
Of course, everybody drinks a little alcohol. They don't ask you how much, they say less than an ounce a day is reasonable for women. 3 ounces is much too much. Okay, so her 10-year probability of a major osteoporotic fracture is going to be 10%, and her hip fracture is 0.8%. Say, wait, she fell in her kitchen and had a hip fracture. Okay, I put this case in because I want you to remember that if she's a little young for this, right? She's 44, but if you fall and fracture a hip, you have osteoporosis, right? A fragility fracture of the hip or spine is osteoporosis, and the radiology department sent me this FRAX calculation when someone sent her over to get her DEXA. Do we need a DEXA in this patient? No. We can use it for baseline, but we don't need it. Did we need the radiologist to calculate the FRAX? No. And it muddies the water. So if they did that, you must put in your chart, this patient should be treated for osteoporosis because of fragility fracture by the NOF guidelines. And if you don't put that, some insurance companies will not pay for you to treat this patient. And they won't pay for you to follow her up with a DEXA to look at how you've done. So if the radiology department calculates a FRAX score on everybody, and a lot of them do now because one of the new software versions comes with that calculation, then it's good for a lot of things. But if your patient doesn't fit, be sure to document in the chart that they have osteoporosis because, and you're going to treat it appropriately according to the NOF guidelines.
And just before we pull out of this, this does give you the option to discard, save, or to email. And I will just make a comment about, remember, however, saving to phone is not HIPAA compliant, so that's probably not recommended.
And I'd say for this one, we ought to just discard.
Yeah.
Okay, here's an interesting case too, and that FRAX works beautifully for people who have osteopenia, and I've sort of taken the odd, exceptional people so we can look at them. But if your patient has osteopenia and you want to know whether or not to treat, go ahead and do your FRAX. Okay, it's a 58-year-old lady who couldn't have a DEXA scan. It was refused by our insurance. And that's going to be happening more and more because the U.S. Preventive Health Task Force says we really shouldn't do a DEXA on the postmenopausal woman unless she has risk factors equivalent to, that would make her equivalent to a 65-year-old woman. Well, you may not know, you may know what those are, just like lickety-split, but I don't. So again, it's confusing, and sometimes the insurance company will refuse your DEXA. Okay, so she's 58 years old. She's 64 inches tall, and she weighs 160 pounds. Is this lady overweight or what? Okay, risk factors. Aha! She has type 2 diabetes and an A1C of 10. So is she at high risk for fracture? You bet. That A1C is going to do her in. She has a mother had a hip fracture at age 96. It doesn't count when. It's not like American Heart. It's not an early family history of fractures. Your mom fractured her hip any time. She doesn't smoke cigarettes, she drinks alcohol, she had menopause at age 52, which is the usual age. She has no arthritis, no steroids. Should she be treated?
Ethnicity? Remember? Ethnicity.
I'm sorry?
You remember her ethnicity?
Her ethnicity, she is Caucasian. In my practice, about 85% of my patients are Caucasian. The others are generally Hispanic. So we're going to go here. She hasn't had a fracture, but I'm going to help you out with this because we're going to do it something else. Okay, keep going. She doesn't smoke. Doesn't use steroids. Wait. Back one? Sorry, I didn't catch you fast enough.
Oh, it's history, documented history of rheumatoid arthritis. She doesn't have that.
Yeah. I'll go back to that. So what do you do for the patient with diabetes? When, you know, they're at higher risk, how do you fix the FRAX? And the National Osteoporosis Foundation this year has come out with a thought. They said what you do is you tick off rheumatoid arthritis, an inflammatory disease that raises your risk of fracture. And that's what type 2 diabetes is, an inflammatory disease that raises your risk of fracture. So if you want to make this more meaningful for your patient with diabetes, you tick off the rheumatoid arthritis section of FRAX. And when they went through and calculated that, John Canna said it was okay with him. It looked like that is going to help us out in the diabetic patient. Saying, what are we going to do to help estimate risk? So you can either subtract 0.5 from the T-score. If you're going to put the T-score in FRAX, remember it has a box that has a T-score. If you're going to put the T-score in FRAX, you just subtract 0.5, and basically it's a minus 1.8, you go down to minus 2.2. 2.3. Again, so my but anyway, so you can do one of those two things to alter FRAX to make it relevant for your patient with type 2 diabetes. They're working on sleep apnea. They don't know what to do for that yet, but you probably could tick off secondary causes. If your patient has early menopause, you can go in and you can tick off secondary causes, and it helps you out there to get those patients that don't quite fit the questions in. I'm sorry, Joan, I was going to catch that before you got it.
Well, and actually, I was going to say that actually does bring up one more con of this app is that you can't go back. So once you've gone past, once you can't go back, you got to relaunch.
I'm sorry, I didn't catch you in time, but yes, if you screw it up, you have to go back. So if you want to change one of the risk factors, you have to go back and just recalculate. So again, it's hard to demonstrate what you do with your risk factors, but most of those are pretty set in stone. I mean, if Mary Jo takes glucocorticoids, you can. They'll say, what'll happen if you don't?
So this would be based on not having answered the rheumatoid arthritis question, which really would not take into account for diabetes, so this is going to be lower than it should be.
Right, so this is way lower than it should be, and she doesn't still quite fit. So she hasn't had any fractures, so she doesn't still quite fit the criteria for treatment, but I wanted to point out what you can do with people who don't fit the FRAX. And the diabetes one is very important, so you got to make a note of that.
Okay. Yes, this is the final one for Frax.
Okay, let's see. Okay, 62-year-old lady sends you for osteopenia. Now this is the ordinary case. T-score minus 2.3 at the left femoral neck on a screening DEXA. And again, you're going to look at that left femoral neck. You're going to make sure that neck box is on the femoral neck. Right? And it just takes a second to do that. Take a look. Weight's 130. She's 5 feet 4. Yeah. No, she's only 54 inches. Okay. No previous fractures. No alcohol. Mother fractured her hip. No steroid use. No secondary causes. No arthritis. There you go. So this is just your usual patient. I think Joan deserves a special round of applause for doing
I
this
can't believe it.
online
Yeah.
on her phone. I never could do this.
Mother fracture.
Yes.
Mother fracture.
We didn't count her as smoking. She's a non-smoker.
She's not a smoker.
No glucocorticoids.
No rheumatoid arthritis.
Or diabetes.
Or diabetes, or sleep apnea.
And your patient filtering 3 things with alcohol.
No, no alcohol.
Right. And she had
That's it,
She had a T-score. And the T-score is plus minus. You can put it in, you don't have to put it in. The calculation works very well without it. The reason they set it up that way is that most places in the world don't necessarily have a DEXA scanner in every car or street car the way we do.
So, and this literally looks like you have to.
John, I think you're going to positive instead
Yeah,
of
go
negative.
back, go down.
Oh, okay, but I mean,
There you go.
you literally have to,
Can you hold it?
oh yeah, you can, okay.
Right.
Good.
But you're right. It is, well, you know, on your screen, you just type the letter in. And I think if I were going to use FRAX, I would use it on my computer screen because I show the patient anyway. There we go. Thank you. Wow. Wow. So age and the fact that she's not obese have really made you think that this lady ought to be treated. So she does have a 20.2% risk of major osteoporotic fracture. So it says that you would treat this lady with a bone active agent.
And what's your first choice?
Well, my first choice is always, if they haven't taken anything else, eliminate. I mean, it's cheap and it works. And the side effect profile is very good. Now, anybody in GYN want to say, okay, you could use, you probably could use Relaxofen in this lady. But her mother fractured a hip, and Relaxofen doesn't decrease the risk of hip fracture. But I would use eliminate. Bisphosphonates are very effective, as we talked about.
One of the really nice features on this one is it actually lists alternate drugs. So if you put in, can you use this, it actually suggests that this is a better choice, which I found helpful. It does include over-the-counter medications, which I found helpful. It says it includes supplements and herbals, but as you're going to see, what it's going to basically tell you is what you already know, which is that we don't have much information. Cons, you have to use complete drug names. So you can't, for example, say you want to look up SSRIs. You have to type that out. And again, there's not data available in breastfeeding regarding some medications or supplements, but when this is the case, that's clearly stated. And again, sometimes that is helpful when you've got a patient who's very insistent on taking an unusual supplement and absolutely wants an answer, and you can just show there is no information. I cannot, give you any advice kind of a response. Okay, so again, looking at some cases. We have a 26-year-old first-time mom. She's 4 weeks postpartum breastfeeding. She has a history of depression and was on Prozac 6 years ago. She presents to your office crying. She's lethargic. She's upset. She's feeling down. She's not enjoying motherhood, which is upsetting her because she thinks she should be. And she wants to know if she can restart her Prozac while she's breastfeeding or if there's a better choice. So in this case, we're going to search the drug by name. And there you can type it in or you can do it alphabetically. Okay, so the first tab is summary of use, and it tells you that the average amount of drug in breast milk is actually higher with fluoxetine than with other SSRIs. And tells you that adverse effects such as colic, fussiness, drowsiness have been reported in some infants. One study showed decreased weight gain, but not others. And then it goes on to say that if it's required, it's not a reason to discontinue breastfeeding. If she was taking during the pregnancy, or if other antidepressants have been ineffective. And again, gives you some information about drug levels, maternal levels, some studies, some references. I believe here at the bottom is infant. So there's also some data about levels that have been found in infants in plasma. So this one is actually pretty comprehensive. A tab on the effect of the infant. Again, colic, decreased sleep, vomiting, had been reported. A couple of the cases, an occurrence of hyperglycemia in one 5-month-old. There. And it actually suggests alternative drugs. And one of those is paroxetine, so you can actually look up the information on paroxetine as an alternative. And it actually says that because of low levels of paroxetine in breast milk, that perhaps this might be a better choice. Any questions about that so far? Okay, so our next case is a 32-year-old G2P2 who's 8 weeks postpartum breastfeeding. Her hypertension was well controlled on hydrochlorothiazide and metoprolol before pregnancy, but this was changed to labetalol QID during pregnancy. And so now she wonders if she can safely return to her previous once-a-day medication because she's having trouble remembering to take that 4 times a day in dealing with this new baby. So we're going to do the same thing, and we're going to type in
Don, what do you think about her? She's taking her labetalol 4 times a day.
Don't need to do it 4 times a day. Once you get to a critical dose, it could be BID. So we would have to know the dosage, but then be able to decrease the total daily dosing regimen. I turned it off. Right. What Ronnie asked was the dosing of labetalol. Do you have to give it 4 times a day? And the answer is no. Once you get up to a certain dose, 200 or 400, you can then give it twice a day.
So if you couldn't get your app going, you could tell her to just take the labetalol twice a day.
And again, we would need to know the dosing.
Right, we need to know.
Try now.
I'm past that.
Okay, yeah, go ahead and unplug
Wait,
it.
let me,
Wait a minute,
there you go. Okay. So we're going to look at the hydrochlorothiazide. Hydrochlorothiazide doses of 50 milligrams daily or less are acceptable during lactation. Intense diuresis with large doses may decrease milk production, which I think is something that we would all know. Don, are you seeing many people use more than 50 a day? Hydrochlorothiazide?
No.
Yeah.
But we've had the other problem. We've had people underdosing hydrochlorothiazide and only using it up to 25 milligrams a day. So we're on a sort of a rampage, if you will, to do two things. Number one, increase the doses of the thiazides that we're utilizing because we've been underdosing thiazide dosage depending on the patient population. If they're ingesting a whole lot of sodium in their diet, you're not going to get that out in the kidney by smaller doses of thiazides. And the second thing we're doing is we're on another crusade. We're failing miserably, but we're trying. We're still charging forward to change from hydrochlorothiazide to chlorthalidone. Now remember that the doses are 2 to 1. It's twice as potent as hydrochlorothiazide, so it would be 12.5 and 25 milligrams of chlorthalidone, but the data is very, very clear that you get further blood pressure lowering, even at equal doses between chlorthalidone and hydrochlorothiazide. So if you want to take that back to your local areas, again, a pearl would be to, as much as you can, to change over from hydrochlorothiazide to chlorthalidone, reduce the dose, though, by half of the chlorthalidone. The problem is they're both generic. The problem is that there's so much larger use of hydrochlorothiazide, the price is still cheaper than chlorthalidone, but they're still pretty low compared to what other drugs we use. And number two, it's still availability of the pharmacies. But we've decided in the global initiative that our diuretic of choice in the formulary for the world, if you will, is chlorthalidone, with secondary, with hydrochlorothiazides as the secondary agent, and the rationale was, if you build it, they will come. So with 1 billion hypertensives around the world, if we actually put it on the formulary as the #1 thiazide diuretic, there's going to be a lot of chlorthalidone being made.
What about potassium in the chlorthalidone group worldwide and for your practice?
Sure. Well, it would be the same. It's an independent worldwide or in our practices. Since it's more potent, it just makes sense that you would get more hypokalemia. But in equally potent doses, it's not any greater. The problem is if you don't understand, if we use higher doses of chlorthalidone, you'll get more hypokalemia. But at the 12.5 to 25, the 12.5 to 25 milligrams of chlorthalidone, you get the exact same incident of hypokalemia as you do with 25 and 50 of hydrochlorothiazide.
What about nighttime urination? Do you urinate more?
Initially, you might. On the other hand, after 4 to 6 weeks, you're in balance. Your plasma volume is back to normal, and that's been shown with hydrochlorothiazide as well. So there is no, and I hear this all the time in my practice, they're complaining of increased nocturia, if you will. That is not, if you did a placebo-controlled trial, that would not happen, especially if you're taking it in the morning, and you're taking it chronically, with your plasma volumes come back to the other thing about the hypokalemia is, we can reinforce yesterday. Once you use the hydrochlorothiazide or the chlorthalidone with a RAS inhibitor, with either an ACE or an ARB, the hypokalemia is almost non-existent. Or at least significant hypokalemia, if you will, because of the reduction in aldosterone. So both those combinations mitigate the hypokalemia.
What's the half-life of chlorthalidone versus ACT?
It's double. ACT is about 4 maybe 6 hours, and chlorthalidone is about 8 to 10 hours. So chlorthalidone is a 24-hour. It's almost like metolazone. Metolazone got all the press with the increased diuresis for cirrhosis and heart failure, but chlorthalidone would be absolutely the same example.
So are you ever starting somebody on a potassium supplement with the chlorthalidone?
No. You don't. Used in those doses, Joan. No, you don't need to. You would check electrolytes about a month later, like you would do anyway. But since we use so much combination medication, and that second combination is going to be a RAS inhibitor, it really further makes the hypokalemia less likely. Now, if they have another entity such as adrenal adenoma, etc., that's the exception rather than the rule. But we're talking about the general hypertensive individual. We're not seeing any appreciable greater incidence of hypokalemia with those doses. I think the hypokalemia got a bad press from my generation. When we didn't have these other agents, we used 100 milligrams a day of chlorthalidone when I started. That was the maximal dose. And if you look at the first studies, that was the maximal dose of chlorthalidone, 100 milligrams a day. You saw hypokalemia in everybody. But those days are over.
All right, so back to this patient. When you look at at the effects of the infant of the hydrochlorothiazide, that looks reassuring as well. No electrolyte abnormalities were noted. And then let's see about alternate drugs. Did it list? Oh, it did. Randy, can you? There. Oh. So actually, that's what the recommendation, the alternate listed is the chlorothiazide. Okay, so then the other question would be her metoprolol.
While you're hunting, John, why would this lady be on metoprolol and not Invasive? But why would she not be on lisinopril and hydrochlorothiazide? Is there a case where you would perhaps choose metoprolol instead?
Well, my understanding is it's probably because of pregnancy. She was switched from hydrochlorothiazide to metoprolol, so you would use the rest during the pregnancy. And then put on labetalol.
No, it says she was well controlled on her once a day before pregnancy.
Right, but then this was, during pregnancy, it was changed.
Right, so why
only on
would you have her on metoprolol before her pregnancy? Your whole kaiser permanente system would be flawed there.
Because they did. Yeah,
Okay.
that would probably not be the regimen we would use today. We wouldn't use that regimen today, not because there's anything wrong with it, but we would use hydrochlorothiazide with a RAS inhibitor, as opposed to the beta blocker, and then reserve the beta blocker for later, as multiple drugs are. Now, there may be another reason that she could have had migraines, she could, some other confounder, but just for hypertension, no, that's an older regimen, and we would not use that regimen today if we had two drug pick.
Okay, so did get the metoprolol to come up, and again,
Wait a minute, Joan, there was
I was gonna, maybe they changed her because she was trying to get pregnant.
So, good question. Do you change your patients when they're do you say, okay, you're on an ACE or an ARB, and if you have proteinuria, this is Jones, do you then change them over before they become pregnant? Or, if they don't have proteinuria, I can see that. If they have proteinuria, do you change them over before they become pregnant?
I personally would not, but I would send them back to their person managing their hypertension to ask them if they were planning on being pregnant, to put them on something more pregnancy friendly.
Yeah,
Although most of the time they just show up pregnant.
that's why we changed it first. If we get some warning, there's no question about this. If you have a young woman that's trying to actively become pregnant and on a RAS inhibitor, you must stop the RAS inhibitor and change to something else temporarily because of you get no warning when the pregnancy is started, and really, we're from Texas, the horse is really out of the barn by then, so we would rather change the RAS inhibitor in these individuals a priority and take no chances.
okay, so the good news is when we look at the metoprolol, that also looks to be okay. Low levels in breast milk, not expected to be a problem. When we look at the effect on the infant, no statistically significant adverse reactions. And then for alternatives, it lists propranolol and labetalol. It's delayed again, but propranolol and labetalol were the two that came up as alternatives. Okay, last. Look up lisinopril? Sure.
Oh, you want to do it? Throw it. Come on, throw it further.
So you can get her back.
That's cheating.
No, I just said, can you look up lisinopril just to see what they say?
Yeah,
Here.
look up my symptoms.
The search function box seems to be working, so I'm going to control the rules. Give me a sec.
We're getting close.
My goodness.
Licorice,
there's licorice, John.
Did you see licorice? No, did you see licorice?
It's a pretty comprehensive. There we go.
I wonder if you can use licorice when you're breastfeeding. There it is.
Okay.
Okay. See if you can use licorice.
You would use it.
I already got Randy's
There-
first
Oh, there it
one.
is.
There it
Oh,
is.
Randy's doing it.
Here
There
we
we
go.
go.
No information available.
Really?
An alternative drug may be preferred.
Huh.
Interesting.
And again, it is nice that it does tell you that. At least know that might not be your best choice. Okay. I'm not working.
Three. There you go.
Okay. All right. So last case, 28-year-old G3P3 who describes herself as fully holistic and wants to know which herbals and supplements are safe for her to take during breastfeeding. She has a long list, but her main concerns are ginkgo, ginseng, and rhubarb.
Rhubarb sounds good. It's a prebiotic.
There's ginseng.
Ginseng, right? Ginseng's very China.
All right, here's ginkgo.
Is it not showing
Yeah,
up?
it's behind. Here we go. So gives you some information about ginkgo and its components. No specific uses during breastfeeding, but commonly used as an antioxidant, a vasodilator to increase cerebral perfusion and improve memory. No data exists on the safety and efficacy of it in nursing mothers or infants. And then a disclaimer about how dietary supplements do not require FDA approval. For effect on the infant, no data available. And unfortunately, when you click alternatives, it basically tells you there are no alternatives. And we're going to find the same thing with ginseng. I think rhubarb actually did have one. Let's take a look. I think rhubarb did have one. That's why I put that one.
Really? Should be rhubarb.
So I definitely need a better lookup. There you go.
This basket of rhubarb. There's two rhubarbs.
Okay, so rhubarb is
Yeah. So Chinese garbage.
two very old studies found that laxative doses of rhubarb given to nursing mothers did not appear to pass into milk or to affect their breastfed infants. But most recent reviewers say that it should not be used during breastfeeding because of possible cathartic effects on the infants.
Okay, rhubarb pie.
So, again, not anything we didn't already know, just that we don't know, but sometimes it is helpful to actually be able to, refer to, in this case, an NIH opinion.
In terms of the ACE inhibitors, you can use the others. There is, I just looked it up, and you can use Captopril or Vasotec. So you can use ACE inhibitors. They have breast milk information on those, and they don't pass over to the breast milk.
Okay, so the next one that we're going to look at is MetaPro, also a free download. This is a North American Menopause Society product. It was designed to assist in managing menopausal symptoms.
Try that. There you go. Go. You should you have. There we go.
So pros and cons. It has two modes, one for healthcare providers and one for patients, to encourage shared decision making, or when they don't believe you and they want to go home and check it themselves, they can. And you can see that on the thing here. There's the healthcare provider and the patient options. This does incorporate age, the severity of the hot flashes, whether the patient has an interest in HRT, or today we're on Dr. Phillips, what are we on? We're on MHT. Her hysterectomy status, race, her smoking status, and underlying medical conditions. It does calculate a 10-year Cvd risk score. It lists out multiple options, including FDA-approved bioidentical options. This can produce patient education handouts and can email a summary. They have a stated bias that only women at high risk for osteoporotic fracture should receive HRTs, and that others should return alternate therapies. Although in going through the app, that didn't seem to come out. It does state that all patients should have a 3-month trial of lifestyle changes prior to initiating any therapy. I personally think that that's a little bit of a challenge because in my experience, by the time that patient shows up in your office stating, I want to do something and I want to do something now, the answer that we're going to spend 3 months trying lifestyle changes is probably not going to go over real well. A con with this one is that the app moves sluggishly, and we're having a little sluggishness with the connections here anyway, but I think when you try it on your own phone, it seems to hesitate and sputter a little bit. And again, I found that the charts and the handouts can be a little hard to read on a phone screen. Randy's suggestion of a tablet may be a better option. Okay, so looking at our first case here, we have a 54-year-old non-smoking Asian female who's complained of amenorrhea for a year, who has a 6-month history of sleep disturbance due to hot flashes. She's not interested in lifestyle. She wants something done now. She has no chronic medical problems, and she denies any prior surgeries. She has a normal blood pressure. Lipids look fine. And she wants to know, is she a good candidate for HRT? So we need to pick the health provider option.
That's the one all your patients pick, by the way.
Yeah.
Okay, how many people do a frax on this lady? She's in the office, she doesn't have a DEXA, and you can get some info from a frax. So probably a good idea just to run that. It costs her nothing.
And the delay you're seeing is actually real. This is what happens when you try to use this app. Yes, she's interested in HMT, MHT. It's been less than 10 years since the onset of menopause. She has not had a hysterectomy. She is Asian. She's not a smoker. Not been treated for high blood pressure.
So, but also she has osteoporosis. There's no contraindication to using a bisphosphonate and your estrogen for raising her events at the same time. They're certainly very compatible.
She does not have diabetes. She is not on cholesterol medication. Okay, so we've calculated a 0.87 risk score over the next 10 years. Since she has an intact uterus, she needs an estrogen plus the progesterone. With that low score, she's a candidate for either oral or transdermal therapy. And then as you go down, We could look at estrogen therapy. Okay, and so it's going to list out combination estrogen and progesterone therapy products and dosages. And I'm not going to click on it because this is really moving very sluggishly. But it would give you options and doses. The next category would be estrogen and progesterone products and dosages when prescribed separately. And then approximate equivalent dosages. It does, let's see when we push the FDA approved by identical options, if we could get that to pull up, that was kind of interesting. And see, this is sometimes the problem. The
You wanna flip-
microprint, it's not
Can you flip it?
It's not flipping. I read it, but I can't.
I think it's just blurry.
Well, it's not blurry on my screen, it's
Oh.
just microprint.
It's just a,
So again, even though I knew that this app was a little bit sluggish and not always the easiest, that we did want to bring that to your attention, is that some of them are a little frustrating. Okay, I'm going to move on to the next case. Okay, so in this case, we have a 52-year-old Caucasian female who had a TAH LSO at age 40 due to pelvic pain and endometriosis. She has been having progressively increasing hot flashes over the last 3 months. She's a non-smoker, but she's being treated for both diabetes and hypertension. Her blood pressure is at goal. The last A1C was 5.8, but she refuses to take a statin because her last lipid panel was at goal, and therefore she doesn't need it and she doesn't want to hear about it. She wants to review all of her options and is willing to consider oral medications, and is probably going to go look up the app on the provider site after she leaves her office.
Right.
yeah.
Do you want me to go through this, or is this too sluggish?
I want to see what diabetes is going to do to your thoughts about HT.
Okay.
Then I want to ask you guys, does it do anything to your thoughts about HT? Patient has diabetes, had it for 10 years. You have an A1C of 8. Does that change your thoughts?
Absolutely.
You want to tell us about that? I'm afraid not.
I would stay away from that lady. She was not getting any hormones from me. I would probably, since she's complaining of hot flashes, I would do one of the alternative, either Effexor or something like that. But she has 2 reasons for this. The time is 12 years from her menopause, and she has. There are some ladies that are 8 to 9 years, 10 years out from menopause who are on a statin who are not going to get that estrogen effect from the
On the cardiovascular system,
yeah,
right?
right. They're not going to break down the atherosclerosis in the arteries from the estrogen. You might consider giving them a transdermal, but this lady would probably would be a good candidate for infection, especially since she didn't want to take a statin. Ready?
Ready. I'm clumsy, but I do.
Still trucking through.
We're still trying through. Okay, so anybody else want to get some thoughts about uncontrolled diabetes and your HT or high-risk cardiovascular disease? Probably not. But would you tell this lady a statin, and then I'll give you some HT?
First of all, I think you overestimate how much primary care we do as gynecologists. I don't think I've ever given anybody a statin, but I would consult back. My recommendation would be against it if she's had diabetes, especially with poor control for that long, because I'm worried about her coronary arteries.
Me too.
And so I think by
That's
her
right.
history, she, in my mind, falls into that greater than 10 years, because what we're worried about in greater than 10 years is cardiovascular disease.
Anybody else have any other opinions on that? Oh, okay. I won't throw it to you.
In my area in northern Louisiana, the OBGYNs now have nurse practitioners, and they have, one of them has gotten the doctor has certification in lipidology, so she runs her own lipid clinic where they see all of their patients and will treat accordingly. And they also have one doctor who likes to play in hypertension, so he has a nurse practitioner who then sees patients primarily for hypertension also.
That's a good plan, the team approach. Did you want to?
I think which underscores that you need expert opinion into it. And I think when we start dabbling as gynecologists, we're not going to keep up when you're presenting these case histories that I'm hearing and you're talking about the proteinuria and the different classes and all that stuff. It just makes my head explode. I couldn't possibly keep up with that and do the gynecology stuff and obstetrics as well.
Well, I couldn't do a pap smear, so.
Actually, that might be an interesting question. How many people here do manage lipids? So good number. Okay. All right, so we did finally get this thing to give us a score, and our Cvd risk is 2.01 over 10 years. And then there are estrogen only options since she's had a hysterectomy. And as you go through, it would list out the options with dosages available. I'm going to, in the interest of time, I'm not going to go through that because it's just sluggish.
She might be a person to get a coronary artery score on. Calcium score.
Okay, and so our last case is a 55-year-old African-American female who presents complaining of dyspareunia and vaginal dryness. She's a smoker. She's on metformin for her diabetes. She's on lisinopril hydrochlorothiazide for hypertension and Lipitor for hyperlipidemia. Her blood pressure is 140 over 90, so not wonderfully controlled. Her last lipid panel, she had a total cholesterol of 205. Her HDL was only 35, and her LDL was 130. Is she a good candidate for HRT, or should alternate treatment be recommended? So the points here, again, I think I was just being too sluggish, but the points here is that the main complaints here are vaginal, local, and then we have all of these risk factors that probably tell us that she's not the best candidate for estrogen. She's probably more of a candidate for estrogen, for cream, for lubricant, for other treatments, a vaginal moisturizer, rather than HRT because of her risk factors. Dr. Phillips, anything you want to add to that one?
I think she just hang on to this.
Yeah.
I would put her on vaginal estrogen preparations, but she doesn't really have an indication for systemic.
Right.
So even if she did, she probably wouldn't get them.
Right.
But I wouldn't hesitate to give her vaginal, although I probably favor the ring or the tablets over the creams because the creams can be absorbed, and as we all know, everybody thinks more is better. So she might be absorbing too much that way.
You wouldn't pick us for your team.
We're going to have practice afterwards.
You guys say we have practice
We'll have practice afterwards.
Okay, so the next one we're going to look at is the CDC's STD treatment guide, although that's a little bit of a misnomer, as I'll show you in a minute. Available both for Apple and Android, developed by the Centers for Disease Control. It's intended to be a quick reference guide on the diagnosis and treatment of sexually transmitted diseases. The pros, again, it's pretty fast and easy to use. It does include push notifications for guideline updates if you so choose. It has a condition quick pick tab, which lists common STDs in alphabetical order, so you can go through it fairly quickly. It does list regimens and then alternative regimens, for example, if someone's allergic to a particular medication. Interestingly, this includes recommendations for both pregnant and pediatric patients, although we would, of course, all hope we would never have to deal with that. This was interesting. You can share the results via social media or email.
Well, that sounds good.
I'm not sure why we would ever want to do that, but, and then I thought this was a really interesting con. There are no illustrations included in this at all, and I don't think I've ever seen any kind of an STD treatment thing that didn't have at least some sketches or something. There are no illustrations whatsoever. The other thing that I found very interesting as I looked at it was bacterial vaginosis and yeast are listed as STDs. So, anyway.
I get you.
You might want to send a picture. That's too bad. You might want to send a picture of your STD on Facebook.
There's a little warning about how fast you need to get in PC.
Instead of doing sexual partners.
Exactly. All right. So this is a 26-year-old primip at 10 weeks who had her initial prenatal appointment last week. She had a negative PAP, but a positive chlamydia. What is recommended and what are the alternatives? So again, on this one, we've got a quick pick list, and we can pick chlamydia, and it gives us adolescents, adults, pregnancy, children, infants, and neonates. So we're going to pick in pregnancy.
There it is.
I think, can you move it over?
Guess that.
No, it's cut off.
It's cut off on my phone.
Yeah.
Oh.
We can all guess.
Okay, so the recommended regimen is azithromycin 1 gram orally in a single dose. Alternative, there we go. Alternatives listed are amoxicillin 500 TID for 7 days. Erythromycin in pregnancy, I'm not thinking that's going to be well tolerated. But again, this one is at least a little quicker than some. Okay, so case number 2, 45-year-old Caucasian female presents with records confirming that she's been treated for yeast infections 5 times in the last year. She was treated with diflucan 150 twice by her PCP. She was then referred to an OBGYN who confirmed a normal hemoglobin A1C, so there's no underlying diabetes that's the issue. Treated with tericonazole. Her symptoms recurred 4 weeks later, and after confirming a negative HIV, so no immunocompromise that we can identify, she was treated with a 5-day course of tericonazole. She was last seen in an ambulatory care center while on a beach vacation, and treated with a 3-day course of clotrimazole. And she now presents looking for long-term symptom resolution. And so there's actually an option for complicated, and it recommends vaginal cultures should be obtained to look for non-albicans species. It goes through some recurrent, which is what we got here, recurrent vulvovaginal, and goes through some treatment recommendations, which would include longer treatment. So fluconazole weekly for 6 months is the maintenance regimen after getting things back under control. So this is not a very common scenario, but it's certainly one that I have run into. I've had people referred that had those kinds of histories. So I thought this was a good example, although again, I find it very odd that this got listed out as with the STDs. And the last case for this app, we have a 30-year-old African-American female who's HIV positive and on antiretrovirals, who was seen for a labial ulcer 3 days ago, and her culture returned positive for type 2. She had a similar lesion 5 years ago, but none since then, so this is not a primary lesion. And what are her treatment options? So chlamydia, and, no, I'm sorry. So when you go to HSV, you actually have a choice for HIV positive, and then it gives you the recommended regimens for daily suppressive therapy in a patient with HIV, acyclovir, valacyclovir, famciclovir, and then recommendations for episodic infection in those same patients. So again, this will give you a quick reference on some of those more novel situations, the ones you're not going to run into in your office every day, but you want to be able to look it up quickly. I did think it was helpful for something along those lines. All right, so the last two apps that we're going to look at are actually a little different in that these are multiple subject calculators. The first one is MD Calc, which again is available both for Apple and Android and is free. This is the mobile version of a website, so the website is available, and again, if that's easier for you to use. This current version actually has 289 different calculators on it, including an Cvd Risk, the GAD7 and the PHQ9, which is why I chose this particular one to look at. Again, pros and cons. So the pro, multiple calculators in one app. If your phone's starting to get clogged up with too many apps, this will give you several options in one. One thing I liked is that you can make a favorites list, and actually what you see here was that's what I did. This is when I opened up my MD Calc, I've just got these 3 listed, you star them, and then you can just have your favorites rather than trying to scroll through all several hundred of them. The calculator on this one does include a high-risk LDL question, which I found more reassuring. The ASCVD evidence section does list out whether the statins are considered high, moderate, or low intensity, and what the average LDL lowering effect is. Of course, that's something Don knows off the top of his head, but the rest of us sometimes kind of have to go, It has both depression and anxiety screening tools. And it does recommend next steps, gives evidence and references and some information about the developer of it. A con, you cannot save the information on an individual patient or generate a report or email or Facebook. So,
Yeah.
Okay, so we've got a 60-year-old Hispanic female with hypertension, which is well controlled on 40 milligrams of lisinopril, no other medical problems, elevated lipid panel. Should she be on a statin, and if so, which one and at what dose? Which is, again, a little different with this one.
We know that. Okay, so everybody knows that, right?
Okay,
Yeah,
so history. So she didn't particularly have a history, so that's going to be a no.
Oh, there we go.
So her LDL is at 190, so that's a yes.
There we go.
So high statin is recommended, high intensity.
Do they tell you why? That's good.
Okay, so then it gives you advice and talks about statin therapy, information about when considering using high intensity statins, things to think about. Guidelines recommended for treating patients. Talks about having a family history before age 55. Some information about C-reactive protein. So again, just a little different than the other app we looked at. Okay, so now we have not looked at any of the PHQ-9s. We have a 19-year-old Asian college student who's home on spring break and presents saying she's depressed. She had some issues with this during high school, but over the last 6 months, she's withdrawing. She's not interested in doing anything other than sleeping. She's hopeless. She's having trouble staying focused at school, and she feels like she's letting her family down. She has thought that she'd be better off dead, but she denies thinking that she's actually about killing herself. So again, we reviewed the Q2 and 9 screening a few days ago. So we can go through and pick that she has little interest in doing things. She's feeling down and hopeless. She wants to sleep too much. She's tired. We don't have any, issues about appetite. She's feeling bad about herself. She's having trouble concentrating. No issues with moving slowly. She has thought about that. And these issues are making it difficult for her to get along. So she comes out as being severely depressed with a score of 20. And then there is a warning on this one that this patient is having thoughts concerning suicidal ideation or self-harm and perhaps needs emergency treatment. The value probably with these scores is that these scores can actually be followed. So after she's in treatment, in counseling, on medication, you can repeat this and you can chart her improvement more objectively than in the past. Okay, similarly, we've got a 50-year-old Caucasian female whose youngest child just left home for college, and she's dealing with empty nest syndrome. She responds that nearly every day she's found little pleasure in things that she used to enjoy doing. She's tried over-the-counter sleep aids and reports that they help about half the time. She's saying she's not fatigued, she's just having trouble falling asleep. She feels like she's letting her husband down because this was supposed to be their time. She answers the remaining screening questions negatively and states that she's only finding it somewhat difficult to get things done because she's been managing to power through for the most part. So again, we're kind of running on time here, but you could enter all of those points as we've discussed. The last one, being a little bit of, how aggressive do you want to get, which she's saying it's only somewhat difficult. The third case, 75-year-old African-American female brought in by her granddaughter, the granddaughter feels the grandma's depressed and needs to be on medication. The patient states that she's been quieter lately because her grandchildren talk too quickly. They're loud, she's not understanding what they're talking about, and so she's just kind of tuning them out. She enjoys reading and listening to classical music, and she says she's not feeling down and hopeless. So when you enter that information in, it's going to say that she's actually not depressed. And again, the value of this may be showing somebody something objective. When you look at these issues, grandma's really not depressed. Grandma is of a different generation than you are, and you need to work on communication skills.
Or get rid of the grandchildren.
We've got 2 cases, Randy, right?
Yes.
Okay, so I'm going to kind of cruise through these last 2 because we've kind of bled into the professor's time, and we do have 2 cases that we're going to go through. So this is just an example of how you would use the GAD-7, which is also part of MD Calc. And yesterday, all we looked at was a print version of a GAD-7 or a paper version, but this is very, very similar. Where it's basically scored, not at all, several days, more than half the days every day. So in this case, we have a 28-year-old Hispanic woman who did her PH2 questions and said she's not depressed, she's just stressed. She's got a military spouse who's deployed to the Middle East for the last 2 months, and since then she's been on edge daily. She can't stop worrying, she can't relax, she can't even sit still. Her children complain that she's irritable, and that what concerns, she's just concerned that something's terrible going to happen while her spouse is away. And those of us who've been in the military know that this is a very common scenario. So I will run through this one just so we can see what this looks like. So she's feeling nervous or anxious nearly every day. She can't stop worrying. She's worrying too much about various different things. She cannot relax. She's so restless that it's hard to sit still. She's annoyed and irritable. She is afraid that something horrible is going to happen to her. And this is causing her a lot of difficulty in terms of getting along with people. So she scores 21, which is extreme, and there we go. So then the next step on this one actually does show you management, breaks down into mild, moderate, severe, and some tools about what to do. And that also reminds you not to forget to rule out medical causes of her anxiety, although all of this seems to be temporarily related to the deployment situation, not to forget about things like underlying thyroid disease or other issues that could also explain her symptoms. Okay, another case for anxiety screening, a 35-year-old female who presents with cold symptoms but mentions that she's really stressed out. And we're finding this a lot as we have routinely now started doing a PHQ-2 as Verifix. It's one of our quality indicators. Once a year, we've got to have documented a PHQ-2 or 9 on every chart that we see. And patients come in for completely different reasons, and the next thing you know, they're screening positive for anxiety or depression. So she states that she struggled with this for several months now, but is having symptoms daily and can't sleep. She's gained 20 pounds in the last 3 months, and she admits that she's stress eating. She has multiple underlying stressors, marital, financial, dealing with teenagers. And so this one was interesting because the question is, does she have anxiety or depression? And a lot of those symptoms could go either way. She's insistent that she's not depressed. So. And again, in the interest of time, I think we won't go through each one of these, but I think you can see that she's going to score fairly highly. And, you know, at that point, we'll be moved on to counseling or treatment. Last case, we have an 18-year-old Caucasian female, presents complaining of increasing difficulty interacting with her classmates. She's starting to skip school because she doesn't want to have to deal with her peers. She denies that there's any inciting incident. She's fine alone. She's not having academic difficulties. There's no history of substance abuse. She's feeling restless. She denies feeling restless or having sleep difficulties. Does she need treatment? And as we would go through this under next steps, it would actually recommend that this is sounding more like a social phobia, social anxiety, and we recommend that you go down that treatment arm. Okay, and then the last of the multi-apps that I'm going to look at is MedEquations. This is actually one that's charged for. I thought it was interesting that it worked on Kindle Fire. This one has 232 different formulas and scoring tools. And I actually thought it was interesting that this was developed by a Texan, actually a resident. And this one has very basic PHQ-9 and calculator. And so one of the differences with this one is that it really just plain old gives you a score. It's just going to give you a number. There are no next steps and no evidence. So it's a much more basic app. Actually, I think, Randy, in the interest of time, we should skip the questions.
Okay.
We'll skip these case studies.
Okay.
So we're going to do the questions at the end of the phone apps, and then we'll do the Meet the Professor.
While he's setting up, what if your patient comes into the office and you do your obligatory foot exam that Medicare is going to pay for you to do with diabetes, and you find peripheral vascular disease? Would you put that that person on a statin? And what kind of statin? Moderate dose, high dose, peripheral vascular disease. Anybody want to hazard a guess there? Is peripheral vascular disease vascular disease? They have known disease, right? Peripheral vascular disease counts. So if you look at those feet, and they don't have any pulses in them, or they have diminished pulses, you've got known cardiovascular disease. One of the simplest ways to find known cardiovascular disease. And that person needs, right, a high-dose statin. Okay. Anybody else have any other thoughts? What was that? Oh, I'm sorry. Got the questions up. Too quick.
Okay, so these are our questions for the end of the lecture. ASCCP Mobile is a smartphone app that, and everyone correctly stated that it's one for the management of pap smears. This one, unfortunately, is not free to download, and it is available to all. You do not have to be an ASCCP member. Which of the following is not true of the ASCVD risk estimator? It is free. Was developed by the American College of Cardiology. It does estimate the 10-year and lifetime risk, but it does not look at LDL values.
Blank.
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 It's blank.
You're right, it's blank. Oh, there we go.
Wait a second.
It expired.
Okay, question 4, which of the following is not true about the LactMed app? It is used to advise breastfeeding mothers on whether they are producing an adequate amount of breast milk based on their infant's age and weight. Was developed by the American Congress of OBGYNs. It was a $9.99 to download from the Apple iTunes Store. Provides information on how medications or supplements can affect breastfeeding or breastfed infants. So this is was developed by NIH, backed by FACOG. And it's actually a free download.
Give it a second. It should catch up.
Okay, question 5. MenoPro is a smartphone app that was developed by the North American Menopause Society. It does have separate modes for use by both healthcare providers and patients, and it does help clinicians make decisions about which patients are candidates for pharmacologic treatment of menopausal symptoms and to choose the optimal therapy. Okay, so I know we have 2 cases that were submitted online for to meet the professors, and some of our participants may have some others, so.
Let's look at the 2.
Do you want to read
You want me
these?
to read them?
Oh,
I'm gonna write them down and run.
I was going to say, you might want to take some notes.
They're pretty long.
Are they long?
Yes.
All right.
Okay.
So this is a 54-year-old, type 2 diabetic, hypertension, hyperlipidemia, stage 2 CKD, BMI 36.5, A1C 9.9. Currently in severe pain due to multiple herniated lumbar discs and is awaiting surgery. Orthopedics is requesting clearance from the PCP. Medications include metformin, XR, 1,000 milligrams q.day, Lantus, 60 units, daily divided, Humalog, 50 units pre-meal, and then it says tries to count carbs and self-adjusts the Humalog. Glimepiride 4 milligrams, Lisinopril 40, and Lodipine 10, hydrochlorothiazide 12.5, gabapentin 600 TID, fluoxetine 60, Xanadine 4 milligrams TID, diclofenac 50 BID. Has refused initiation of statin at this time. Patient insists they are compliant with meds and diet, but is barely able to walk at all due to back pain. Now checking finger sticks regularly, EKG is normal, chest x-ray is normal. Has recently had a cardiac stress test for unrelated chest pain symptoms, which was negative. There's no endocrinologist in the area that's in the insurance network. What would you do to lower the A1C, and would you give clearance for orthopedic surgery?
Okay, well, this is a level 5 consult, so generally speaking, I would charge about $1,000. So, chime right in, John.
Oh, this is your area, Dr.
But I'll tell you that
run a
orthopedics would not even consider this person. They wouldn't even consider it. I don't care how bad their back pain is, 9.9, putting in hardware, you're going to get an infection.
There's no way.
Orthopedics says an A1C of 7.
Yes.
Okay, and if I can talk them into a 7.5 if they're at high risk for hypoglycemia. But right away, this person is a long-term discussion because they're not going to touch them. Now, the other thing is that I would send them to pain management because this is just a mess. And that while they're waiting for their hemoglobin A1C to be 7.5, they need to go to pain management and get this all cleaned up before they go to surgery. They're addicted to things. The surgeon isn't going to want them. All right. So they're on numerous things. Let me see. Metformin you're going to keep. You have to stop it for surgery, but nonetheless you're going to keep it in the long run. You're going to stop it about 48 to 72 hours before surgery. They have stage 2 renal disease. That doesn't bother me. You go to surgery to stage 2. That means they have some proteinuria, probably. But nonetheless, that's okay. And I'm going to just, I'll get rid of the glimepiride. It isn't doing any good anyway at this moment. And you're just going to maximize the insulin. So you're going to keep the metformin XR for time until you go to surgery, 48 to 72 hours. Maximize the insulin, and you're going to raise the Lantus because you want to get the morning blood sugar down. Back to how many times do you have to check your blood sugar before I will take you on as a patient? Once a day, vary the time, okay? So you're going to start with the fasting sugar. There's an old rule that says fix the fasting first. I'm going to raise that Lantus and divided doses. You don't need to divide it really until the patient until you get about 80, because an 80 is the highest dose that you can give at one time with a pen. So right away, we're probably going to go to 80 of Lantus a day. If you want to divide it, it's up to you. And I use the Humalog pre-meal. Tries to count carbs, self-adjust. Forget that, I'm sorry. You're going to let me count your carbs. We're going to go over how many carbs you eat. I'm going to use a ratio of about 1 unit to 5 grams of carbs. This is type 2 diabetes. You're looking at 1 unit for 5 to 10 grams of carbs. It's totally out of control. I'm going to use 1 to 5. And I'm going to use a correction factor. That is there with steroids in there? Steroids? No. Okay, no steroids. So I'm going to use about 2 to 3 units for every 50 greater than 150. So BMI of 36.5. You're going to use about 1 unit per keg per day to start. My arithmetic isn't good enough to know if they're on that yet. But I'm going to raise the Lantus, fix the fasting sugar. In the meantime, I'm going to get this person on a reasonable amount of Humalog. And can you fix this person with just Lantus and Humalog? You bet you can. When they go to surgery, you're going to take the Lantus. You never stop the basal insulin. Even orthopedics knows that now. Are there any orthopedics? No, thank goodness for you. So yes, you're never going to stop the basal insulin, and you're going to use probably the anesthesiologist to use an insulin infusion with rapid acting over the basal insulin during the surgery to control the blood sugar. So that's what I do to lower the A1C. I definitely wouldn't give clearance to this person until their pain meds were fixed and their glucose was fixed. Okay, any thoughts on that? Anybody have any other thoughts on that? How about the endocrinologist, the diabetes person back there? Any thoughts? Anybody do anything different? Okay, okay.
There's one more case, Randy.
Second
Yeah.
case, Randy. Okay.
Next one's yours.
No, I don't think so.
Keep going, Ron.
69-year-old who asks for more thyroid medicine due to persistent lack of energy. Her most recent office visit less than a month ago, her blood pressure was 138/76, her BMI was 30.7. She has a history of hypertension, hyperlipidemia, generalized anxiety disorder, pre-diabetes. She's had multiple abdominal surgeries related to a perforated diverticulitis with colostomy and reversal 10 years ago. She is allergic to ACE inhibitors, is on Synthroid, Vibrid, Simvastatin, and Lodipine, Miralax. Her TSH was 1.25, LDL 100, glucose 109, A1C 6.3, creatinine 0.63, hemoglobin 13.3, normal LFTs. What's your approach here, Dr. Peasy?
Okay, we're gonna fix this lady's microbiome. But first, she's the person we have things like this. She is on an adequate amount of thyroid hormone, and her TSH is 1.25, so it's less than minus, and then 2.5 rather. So what are we gonna do here? She's feeling fatigued. Well, she doesn't even have subclinical hypothyroidism. So I'll tell you what I do for these people, and it is not facetious. I go through their whole list of symptoms, and I look at what can cause fatigue. And so, I really don't go through this carefully, but I tell them in the end, your TSH is normal. Your circulating thyroid hormone level is normal. What we're going to get to do is to get a total T3 to make sure you convert adequately, because some people do not convert adequately from T4 to T3. She doesn't have congestive failure or renal insufficiency, so that won't be a problem in the conversion. She doesn't have euthyroid 6 syndrome. So go through, I get a good exam, I would get an ultrasound of the thyroid, and make sure that there are no problems with this thyroid or the thyroid hormones. And then I say to this lady, ma'am, your problems are not from your thyroid. Say that after me. We all can say that. Your problem is not from your thyroid. If you just practice this at home, you can say this to people and they won't. But seriously, that's true. And so if you're a primary care doctor, this is tough because what I say to them, and you should take up these problems that we've just discussed. Your prediabetes is what's going to probably, and your hypertension could kill you. Your thyroid problem is not the cause of your symptoms.
Yep.
So your answer is punt to the PCP.
Well, my answer is actually no, because what I would do with this lady is I would take a good look at her dyslipidemia. Her LDL is 100 and she has prediabetes. And I'd say, okay, what kind of a statin do you want? And I would counsel this lady about food plan and exercise program. You'd be amazed what exercise does for people who have anxiety, who have lack of energy. It really does help them. The other thing I would do with this lady with hypertension that I would send her to Dr. Petty for is, does this lady have occult congestive heart failure? I see a lot of people who report, the ladies come in. Well, the other day I saw a lady who said, oh, I'm just tired all the time. I said, your feet swelling? She said, sometimes, da-da-da-da. And in the end, I got a BNP and it was 356. That's heart failure, folks. And so I see a lot of people who have underlying congestive heart failure, who have partly uncontrolled hypertension, people who are having terrible sleep disturbance. One of the most common causes of fatigue in the United States today is sleep disturbance. And I would probably send her, what's your BMI?
30.7.
30.7. Okay, nonetheless, I would send this lady over for a sleep study. So, there's some things I would do. And now...
Well, first of all, Ron, thank you for talking about heart failure. She's not going to have systolic heart failure.
No.
Most certainly. Maybe she will. But she's going to have the one we're just talking about with spironolactone with preserved ejection fraction. She's going to have the old-fashioned diastolic heart failure. She's going to have it at all. So I would get an echo for sure. I've seen a lot of patients with diastolic heart failure that have decreased exercise, exertion, maybe fatigue. Usually not at rest, but it can certainly happen at rest. Age is a critical factor for diastolic heart failure. All of our, by the way, as we're aging year over the week, our diastolic function has decreased because our studies showed in the early 80s when we first got Doppler echocardiography, we published a numerous amount of studies showing that age alone decreases your diastolic function. On top of that, hypertension is linear and additive. Diabetes on top of that further. So she's got all the markers for early diastolic heart failure. Echo you'll have to have a really, really good echocardiographer because they'll all just say mild diastolic dysfunction. But nevertheless, with a really, really good Doppler echo, we could determine that and then you can approach that. There's no magic bullet for preserved ejection fraction heart failure. Beta blockers work by just decreasing heart rate. Mild diuretics, but not intensive diuretics, will help, but it's mild diuretics because you don't want to overly diurese them because their function depends on high atrial pressures to fill that left ventricle. It's the opposite of systolic function. So that's what I would think, and I commend you for that because we're not thinking about that enough. As the SPRINT trial showed, none of those individuals had overt heart failure. Yet heart failure was the thing that was substantially reduced in those outcomes. Remember, we went over those. And the mortality associated with that, or at least seems to be associated with that, was decreased to the exact same extent. So, really, really a tip of the iceberg that we're now seeing as we more aggressively treat blood pressures.
Anybody want to raise your thyroid hormone dose? Or TSH is not low. No. Okay.
Not in a 69-year-old.
Right. Okay. So I just wanted to make sure there wasn't somebody who, if she was 30 years old, you might say, well, I'll put you on 150 mics. There's a great placebo effect there. But that's going to make her pre-diabetes perhaps turn into diabetes because that makes you change your glucose tolerance. This lady has metabolic syndrome. And she also has a gut that has some problems. So again, I wasn't kidding when I said I'd fix her microbiome. I think she really needs to get going on that.
And from the question here from the clinician in the trenches, is the diagnosis of fatigue going to clear for the echo? If the diagnosis is fatigue, I'm going to order an echo based on that? What are you going to use as your diagnosis to get that echo?
Metabolic syndrome.
I would say, yeah, we either say metabolic syndrome, or I would also say looking for diastolic dysfunction.
Right,
Heart failure, preserved ejection fraction.
I don't think there's an ICD code.
Well, that's what I would write, and then I would let them fight me. I would fight you from there. Oh, another tip, and I know that this is going to be trickier for all of us, but physical examination does help. S4. Listen very, very closely for an S4. I guarantee, I would almost bet that she'll have, in this case, we're making this up, of course, but in this case, she'd have an S4. If she has an S4, she has significant diastolic dysfunction. So listen carefully for an S4. And there was a question back here.
Actually, a comment from a PCP that works at a federally qualified health center. So money is always an issue. Before I sent this person for any of the tests that you all discussed, I do a PHQ-9 on her.
Yeah,
There's a 30 to 50% chance that that'll be positive in treating her depression, would get rid of her symptoms. The other is people with a persistent lack of energy. I was asking, does sleep make it feel better? Because that's a great screen for whether or not they have a sleep disturbance. And those are cheap.
Yeah, absolutely. Just like what's listening for an S4 is free. You already paid for it by walking into the exam room.
Okay, anything else for this lady?
I know, that's what I mentioned. My residents and students, by the way, Mira mentioned that they walk around with echoes in their pockets. They don't even have a, I mean, a stethoscope is an ornament for them. You know, they hang it on their walls now.
Okay, Randy asked me to see if we had any other cases from the audience to present. Before, if not done, we're going to let you review your
last one.
And unless we have any other cases that the audience, oh, we got one.
Burning desires. Okay, hold on, I'll get it. Where are we?
Back
Oh, jeez, would you?
Just throw it.
I don't know what I'm going to do with this group. I'm going to, no, this is hand delivery.
You got 50 steps in. I have a large number of perimenopausal women in my practice. And since there's been all this hype about men with low T, I've had several come to me and say, well, can't I have a low testosterone? And they're usually people who have been tried on estrogen postmenopausally and sometimes played with the dose and all, but haven't had much response in terms of their symptoms. Usually night sweats, fatigue, weight gain. They want to know, can they go on testosterone.
Pretty much Dr. Philip answered that.
Yes, right. Definitely.
I do not give testosterone anymore.
Oh, yeah.
There are no FDA approved testosterones. I think when you get into the compounded testosterones where you're aiming to give a systemic level, I think there's too many red flags, there's too many societies that come out against that. So I have stopped giving testosterone. I know that a lot of people use it off-label. I'll give you two anecdotal stories, and even though we practice evidence-based medicine, anecdotal stories still matter when they're personal. The very last person I gave a testosterone gel to, and again, you give androgel and you tell them to use 1/10 of the dose. Well, nobody ever uses 1/10 of the dose, and the last person I gave a testosterone gel to had a stroke, which turned me off to it quite a bit. I do admit that for, again, my vulvodynia population, I do use a lot of compounded local testosterone for vulvodynia. I have not had them report to me increased desire. However, they're a vulvodynia population, so they're still having pain, so desire would be an incredible success in that population. I do tell those patients with the gel, if they start seeing an increase in acne, which is usually the first thing that they see if they're getting a systemic level, that they should back down their dose. If I were going to give testosterone, I'm not a big proponent, as you can tell, of blood levels of hormones, but if I were to give a testosterone compounded, I would certainly follow testosterone levels because you don't want to get them out of a physiologic range. I mean, that's another problem with testosterone, is that there's no good normals to what you should be aiming for, but you want to make sure that you're never going above what should be the top normal. And in a postmenopausal woman, I wouldn't go beyond what would be a top normal for a postmenopausal woman, because then I think you get into problems. And I also wouldn't give it without giving concomitant estrogen therapy, because that's also the little asterisks in all of the recommendations. Although I know there's at least one study where they're showing it without concomitant estrogen therapy, without an increased negative side effect profile, especially in lipids, but that's just one study. And the other thing that concerns me about testosterone, because believe me, a testosterone approved for women in this country would thrill me. But in Europe, where they've used it quite extensively, they've started pulling it off the market in Europe as well. And I've been trying to find why they're doing that. It doesn't seem to be a side effect thing. I don't know if it's an economic thing, but even the ones that were available in Europe aren't so available anymore. And that makes me nervous.
Partly that was an outcome thing. Remember when the folks had the testosterone, the topical testosterone, they were going to use that pharmaceutical company. The FDA went through they jumped through all the hoops, and in the end they said, but nothing changes in these people significantly. And so the FDA said, forget it. Everybody's going to use it for the wrong thing, and nothing's going to change significantly. So that was the rumor I